Good morning, everybody. How excited are you to be here? All right, so we are excited to be here to teach you about our new patient-centered medical home program. It has been a long time in the making, and we are thrilled to have this opportunity to let you all know about it. Hopefully you will find it as exciting as we have found it, and we are, just like I said, looking forward to this opportunity to interact with you, get your reactions, learn from you, and then make it even better into the future. That's always been NCQA's goal. We continually look to enhance the program to address issues and concerns that you all bring to us. Today's learning objectives: learn the core attributes of being a patient-centered medical home. This morning's introduction is really about what is a patient-centered medical home, why are we doing this, what do we hope to accomplish in transformation of practices. We're going to give you the details about how the new process works for NCQA in terms of gaining new recognition, how you're going to work with assigned representatives, and take a look at some of the some more challenging criteria that we have available within the program. All right, so a little bit about NCQA. How many people here are already recognized? And how many people here are certified content experts? All right, so we've got a fair group of people who's brand new to the patient-centered medical home program, at least NCQA's version of it. All right, so we've got somebody that's got two hands up. So, you know, we try to make this program accessible and informative for those with experience and those that are new to it. Of course, it helps that the whole program is new, and so for many of you, even if you're familiar with NCQA, you're going to learn some new lingo. We are going to get it wrong a few times because we've been steeped in the old language too, so bear with us. We will try to own that when we make those mistakes, but try to keep us on track in learning the new way of thinking about patient-centered medical home recognition with NCQA. I think all of our goals, we can kind of rally around this idea of high-value healthcare being the goal of a quality, systematic approach to care. We want to help move people from one end of this chart, the bottom right, to the top left here. We want people to stay as healthy as they possibly can, and for those that find themselves in that lower right portion of this chart, we want to make sure that they're getting the support and resources that they need. So patient-centered medical home is about meeting people where they are. We want to make sure that people are getting the resources that they need and able to live the healthiest life that they can. With our program, we want to make sure that we are allowing you as practices to tell your story, to identify what are the needs that your patients have and meet those needs however you see them. So you're in a community and you are in an environment and you have other providers in that environment, and we intend this program to allow you to shape a medical home that works for the environment that you are in. So a little about NCQA, if you're not familiar, but you mostly are, I think, if you're here. NCQA is about measurement, accreditation, recognition. We want to make it clear what our expectations are. We believe in really trying to identify the distinct criteria, being as objective as possible about what quality means. And so we have our clinical quality measures known as HEDIS that we've been doing for many years for health plans. We are moving into that realm for physicians and accountable care organizations. We accredit health plans and accountable care organizations, disease management and care management organizations, and then we recognize physician practices. We have our mission to improve the quality of health care, and we do that through measurement, transparency, and accountability. We want to make sure that you shine a light on the areas where you can best serve your patients. We want to create transparency, both in our expectations. So as we work through a consensus process to identify what are the expectations that various stakeholders have of the entities that NCQA reviews. We want to bring then to light those requirements so that you know what you need to do in order to succeed in today's environment. And then we want to be transparent about how you perform. So we put out there report cards on health plans and on physician practices to let people know this is a practice that has achieved the objectives or the criteria that we've laid out. And then accountability. Once we measure, we can track them for improvement and we can expect progress over time. So NCQA's recognition programs, we have been involved in this space since 1999. Oh, well, Patient-Centered Medical Home since 2008, but before that we had our diabetes and heart stroke recognition programs since 1999. We've worked with a lot of different physician practices on both measurement and on systems and sort of the practice site reorganization that happens with things like patient-centered medical home and specialty practice recognition. You can see here what some of our numbers look like. We have seen, tremendous growth in the patient-centered medical home program over the years we've been operating it, although we had a predecessor to patient-centered medical home in 2002 or 3 is when we put that forward. It became the patient-centered medical home recognition program when the primary care societies came out with their joint principles of the patient-centered medical home, and we had something to rally around to put forward. These are the ways in which one demonstrates that you are operating consistent with those joint principles. So that was the origins of the patient-centered medical home program, which is the little point at the bottom of this chart, and then you can see how the growth has really accelerated over time. NCQA has both the patient-centered medical home. How many people even know that we have other practice programs that are for other types of practices? So, okay. So we have been working to expand the activities in engaging practices in healthcare reform in their own sort of transformation of their practice. We want that to be knitted together into a whole neighborhood of care providers. And so the patient-centered medical home with the patient at the middle is, of course, our touchstone and where we want everything to build out from. But then we've established the patient-centered specialty practice recognition to allow for the medical specialties that need most to connect with the medical home and the primary care. We heard this directly from our primary care providers that we were working with. We can't serve as a medical home if we're just an island and there's no one else sort of engaging and communicating and coordinating care with us. So we wanted to establish a framework for the specialists to be brought into that. Likewise, there are many other care sites. People call it the democratization of healthcare, but whatever. It's people want care where they want it, when they want it, and so retail clinic sites, urgent care sites, these other facilities are cropping up and creating telehealth, for that matter, creating other ways for people to get access to the care that they need in the timeline that works for them. And so with those sites, we created the Connected Care program, Patient-Centered Connected Care, giving those sites an opportunity to demonstrate their willingness to be a part of a neighborhood. So overall, across those site-specific programs, we've got over 12,000 sites that have been recognized. Clearly, the patient-centered medical home is the bulk of that work, but we've had an increasing number of practices demonstrating interest in the specialty practice program, in particular large health systems. How many of you are part of sort of a health system that includes specialists and primary care? So this gives an opportunity for that health system to think about how you all want to work together, how you want to create relationships that serve your patients well and coordinate care towards this high-value ideal. So anyway, you can see where some of those sites have been located. Clearly not as many incentive programs in place for specialty practices as there have been for primary care practices, but we've had some increasing interest because of things like MACRA, and I think we talk about that later today. All right, so current landscape, we're looking to see rewards for value. That is a theme out there, certainly with MACRA legislation, switching over from the way that people have been paid with fee-for-service systems towards value-based payment models. There's just a lot of focus on that area. We, of course, all want to improve quality and increase the integration of care across the health system. NCQA's recognition looks to acknowledge those practices that are operating as medical homes. We do this as a group of clinicians that are working together in a single practice site location. That is the entity that we will recognize. The clinicians who operate there and serve a panel of patients, can be selected as their primary clinician, are the ones that we will highlight in our directory, and you will list in your recognition. We do recognize nurse-led practices, the advanced practice nurses and physician's assistants who have the ability to practice independently in certain states. Those are also eligible for the program, and we've identified already that clinics like urgent care clinics or those that are seasonally operated, they fit more in our connected care program than in this one. I already mentioned that recognition is at the site level and who is listed, and we would want to list each clinician. If they operate in multiple sites, we would want them to be listed in each site. And mostly this is for your purposes so that patients can find you in our directory, but also for payment purposes. Many payers want to see the individual, the clinician ID, and the site that they are practicing out of in order to grant rewards of whatever sort there are. Our expectation for the medical home program is that you are serving as a medical home for all of your patients. We operationalize that as roughly 75% of the business that you do is of that type. We know that every clinic likely has some amount of just walk in off the street, or maybe not every clinic, but there are those that do, or where they cross cover for another practice, and so you're seeing on more of a episodic basis, a few patients. But by and large, we're expecting that most of your patients are coming to you for their full-on continuous primary care needs. All of the eligible clinicians at a site need to be listed. This isn't for part of your practice. Your whole practice needs to come forward. This is a way of operating. This is a system of care. And so you can't have some that are willing to do it and others that aren't. We generally say don't list the physicians that are in training. Usually they're being overseen by a physician who's already out of training, and so that's the one that you would list. So for residency programs, we generally do not have you list the individual residents. You do, in engaging with NCQA, you want to make sure that you've got some staff who can work with the computer systems and the various tools that you'll need in order to engage with NCQA, but also to just do the work of the practice. Many of you, who here operates a paper-based practice? A little paper, but yeah, for the most part, we've moved to electronic systems for at least electronic prescribing, some amount of registration systems. Who has an actual full-on integrated electronic health record? All right, so most of you do in fact have that. So, we're not requiring that you have a full integrated electronic health record, but we do expect that you have some electronic systems that help to support the activities that you're engaging in. And the staff that are working on the transformation of your practice and engaging with NCQA explicitly will want to have some of those skills, how to access your systems so that they can then walk us through, as you'll hear in the new program, through our virtual reviews and so forth, demonstrate to us what it is that you're doing as a practice to be a medical home. We acknowledge that, transformation is a journey, right? Tired saying, I guess, but, and recognition isn't the end point. You will continue on with your work to enhance and continue to evolve your medical home to serve the patients that you have in your community. So we do think that transformation as a whole is going to take you, 3 to 12 months. We have set up this new recognition process to really work with you throughout that transformation. So you're going to hear about the fact that you'll commit upfront to the transformation. You will then engage with us throughout that transformation, and then you will succeed by maintaining and sustaining your recognition through annual reporting. But we really are looking for you to make this commitment, to make the change to your practice, to establish new policies and procedures, to maybe establish for the first time policies and procedures. I know every practice thinks that they're operating in a consistent manner, and the reality is, we've heard time and time again, I was really surprised that not everybody is doing X or Y or Z within my practice, or that, Mary didn't know that Joe does this, and vice versa. And so it really creates this opportunity for you to work together to figure out how are you going to operate, make things more efficient, make things more effective and reliable as a healthcare system. So anyway, you can see some of the changes that you're likely to be engaged in over that period of transformation. The standards themselves really are aiming to achieve the triple aim. You've probably all heard of the triple aim. Some of you may have heard of a quadruple aim. Heard about a quadruple aim? So I choose not to use the term quadruple aim because it's confusing to people, because if you're in the military, it's force readiness. And if you're an employer, it's workforce preparedness. Others mean the idea of joy in practice for primary care providers. So if I use that term, I'm not sure what anybody will think I mean, and so I choose not to use it. We want all of those things to happen, of course. We want people to be more healthier and more prepared to engage in their lives the most of the time that they're not spending with you in their healthcare system. But we also want primary care to be a desirable profession. We can't have a continued loss of that workforce. We need primary care providers to be out there and really engaging with our patients and supporting them. And so we want to make sure that joy in practice is restored and that it feels worthwhile work. We also want to achieve this triple aim around improving the health of populations, improving the cost of care, and improving quality, the patient's experience. Another framework that we had in mind as we went forward with the Patient-Centered Medical Home Recognition Program is this Institute of Medicine report on crossing the quality chasm, really trying to systematize and think about population health management principles, not have the reactive healthcare system that we've had in the past, and create a way of delivering care that has reliability to it. So you can see, the 10 rules that, made up some of the Institute of Medicine's report back in 2001, patient safety, patients in control, care of a continuous healing relationship. You can see sprinkled throughout this. You can see the joint principles of the medical home sort of sprinkled in here, that they had a foundation in some of this. So transparency of information, anticipating patients' needs, really thinking about the waste in the system and looking to eliminate that. Some of the other theories, the chronic care model, Ed Wagner out of the McCall Institute, put forward this approach to establishing a proactive patient that is ready to be engaged and a prepared practice team that is prepared to meet patients where they are and help them to support their health care. Clinical information systems underlie it, having a decision support framework, engaging throughout the community. Again, all principles that you can see throughout the patient-centered medical home model. The patient-centered care sort of dimensions that have been laid out, cultural competence, assuring that we are focused on the diverse needs of the populations that we serve, and then the joint principles of the medical home listed in that last column. So a lot of foundation to the requirements that we've put forward and have the opportunity to refine over the many years that we've been working in this space. Primary care, the patient-centered medical home being, care the way patients want to engage in it. All right, so long-term partnerships, people want, so we had an interesting opportunity. We engaged with focus groups in the Philadelphia area, a group of patients who were with a patient-centered medical home practice, sort of one of the early transformation practices, and then another group of chronic care patients who were in sort of traditional practices. And what we heard from the ones who were in traditional practices was, they heard the description of what a patient-centered medical home was, and they, said, oh, that would be lovely, but my doctor couldn't possibly do that. They're so busy. The staff is so busy. And they can see the exhaustion on the faces of their, their care team. And, those that were with a medical home were like, yeah, that's the care that we're getting. It's what they could describe, all the dimensions of what we are looking for in a patient-centered medical home, that it's connected. Oh, the doctor has my back. The staff really is part of the team, and they know who I am, and they know what I need, and they've got ability to remind me about services and so forth. So they really do get the concept of a medical home. They may never understand the term. It's a terrible term. I don't know who came up with it. It wasn't me. But we know that term is not really resonating for audiences, but it is what we've been using, and it's what people understand now. It's hard to get across what the concept is. They think it's a place, but they do understand the principles of it, and what care really looks like when it's patient-centered. So we think that it's something that everyone should be striving for and is achievable. All right, so I've mentioned already that we worked to establish the patient-centered medical home criteria in order to really identify those practices that were operating consistent with the joint principles of the medical home. We've now looked to enhance those over time and include things like behavioral health integration. So we're going to talk about that today as a new aspect of the program available to you. All right, patient-centered care, making sure that you have an ongoing, continuous care relationship with patients, that you have responsibility for all their needs, not just when they show up in your practice, that you really are thinking about them ahead of time, that you've got systems to track what they need, what they should be receiving. You're supporting them throughout their care needs, whether those are acute or chronic or just minor episodic and wellness care. A team-based approach. This cannot be overemphasized, the importance of really embracing a model of care that isn't just about the top clinician in the practice, that you need to bring together everyone in the practice, the person at the front desk, the person behind the billing counter, whatever, and everyone within that practice has something to contribute to the delivery of a seamless care experience, one that is thinking about that patient outside of the practice, the face-to-face office visit. And if you do not embrace that model, you will burn out. Whoever is carrying these additional loads is going to be exhausted, and they're not going to be able to sustain it. So really important that you identify what are the skills that we all have, and how can we each contribute to this care process and this care delivery model. I think this is intending to speak to this idea of if we don't do something about the primary care, shortage, and really create an environment where primary care is a desirable profession and one that people really are feeling enthusiastic about serving in, we will have the continued decline in the number of primary care providers and hopefully patients that really do still need primary care and are increasingly in a position to have access to care. Well, I'm not going to go into policy. So anyway, important that we do expand the capacity of the primary care system to care for populations, and having a team-based approach is one of those ways. You can manage a larger panel of patients if you have others that are really helping to contribute to it, and each person within that team is practicing to the top of their capabilities and their license to practice. You know, healthcare costs continue to rise. This one's a little bit dated, but you know, I don't know what today's numbers are, but probably tripled since the earlier 2002 numbers. You know, we have a lot of chronic care or chronic conditions. You know, Medicare patients see, I think I heard 10 different physicians in a year. I mean, it's ridiculous how much healthcare need there is, and if we can manage as much of that healthcare need in primary care as possible and really help individuals live healthier lives and know how to care for themselves, we will all be served well. So, you know, with healthcare spending continuing to rise, I think, let's see, 30% or $700 billion on unnecessary healthcare services. So this idea of inefficiency, low-value care. I think there's been a couple of articles recently that I've seen this term low-value care being, you know, cropping up. We just had a guest speaker in at our office identifying the variation that occurs in certain services. You may have heard of the Choosing Wisely campaign out of the American ABIM Foundation. You know, really, there are so many signals that there is a lot of waste in our healthcare system. We really need to try to eliminate or at least reduce as much of that as possible. We do have a challenge on our hands in that we continue to have a system, a payment system that rewards volume over value. There is movement in the right direction in my view, you know, towards that value-based payment model, but you know, there's still this mix of payment models, and so making sure that we all advocate for payment models that will reward the non-visit care, the coordination, and the idea that you are really managing, doing care coordination across time, not just during those face-to-face encounters that are typically billable. You know, so anyway, you can see some of the challenges that we face in trying to establish a more rational payment model and a more appropriate way of delivering care and meeting the needs of patients as we move to, you know, bundled payments and capitated approaches, or you know, a total budget, total cost of care kinds of models. It gives health care providers and systems the freedom to establish processes and you know, have more phone-based interactions or internet-based interactions, telehealth, you know, all these things that have not typically been reimbursed for, but you'll have those resources available to you to make it really work. As we moved from 2014 now to 2017, here are some of the areas that changed in terms of the content. We wanted to improve the focus of the standards, so we went from 167 factors in the old lingo to there's 100 criteria laid out, but you don't, a challenge that we've always had is that everybody thought you had to do everything. You really want to check every one of those boxes. I know that everybody wants an A+, you know, an extra credit and whatever. We really always intended that there'd be this flexibility. You didn't need every factor in order to earn the full credit of an element even, and you didn't have to earn the full credit of every element in order to get recognized. You know, we had a lot of flexibility intended and not felt by our practices. So our new approach is really intended to make very clear there are some core criteria that you have to meet. There's still a lot of flexibility in how you go about meeting that. We'll get into all of that as we go through the criteria and the competencies throughout the day and tomorrow. But you know, you're really trying to establish the core functions of being a medical home: proactive care delivery, access that meets patients' needs, et cetera. And then we have a series of elective credits. So, you know, college course catalog, right? You know, you don't have to earn every single course that's in your college course catalog. You just need to earn the ones that you that makes sense for the major that you have, for the patient population you're serving, the community that you're in. And so we're looking for you to pick and choose among those elective credits and create a medical home that works for you. We want to make sure that transformation of the practice is sustained and continues in focus on quality improvement over time. The gap of 3 years between recognition processes really created this opportunity to think about the patient-centered medical home as a project that you did to prove it to NCQA, and not really just the way that you operate as a practice. So our new model takes you from that sort of episodic engagement with NCQA to a continuous one, where every year you're going to be checking in with us, and we're going to have this opportunity for you to demonstrate you've sustained the model, but it's not this big project every 3 years anymore. We want to make sure that we had new ways of demonstrating, of showing us evidence that you are practicing as a medical home. We want the recognition to be a byproduct of the transformation of your practice, not something that you do separate and apart. And so we've put in new ways of demonstrating your practice's activities, including this idea of a virtual review where you can screen share. So how many people love to do screenshots out of their computer system and blind it for us? Yeah, is that your favorite thing to do? Yeah. So we want to eliminate that. That's really non-value added work, let's all admit. It helps us see what's going on, but it doesn't do anything for your practice. It doesn't help you to serve your patients better. So we want new ways of you being able to show us these things. And then emphasizing this comprehensive integrated care was a focus for us. And that includes, not just chronic medical conditions, but behavioral health needs and social determinants of health. A person is a whole person, and they come with a series of issues that they need to have addressed. And if you're not at least cognizant of the range of concerns that your patients have, the fact that they are diabetic and they don't have access to refrigeration, and they can't, they have no fresh fruit in their community, or whatever their various social needs might be, that then contribute to their ability or inability to manage their health effectively. So having that full picture of what the needs of your patients are, you don't have to fill every need. You can't possibly provide housing to every individual who does not have access to housing. But if you know that they are homeless, you have a different insight into the issues that they're facing in managing their health. And so, some community health centers certainly do have that ability to connect people with housing resources or other social services arrangements. Others do not have maybe that same infrastructure, but being aware is important to managing the patient's needs. So those are some of the key changes in the content, and we will again go through it. But our biggest change were really around the structure of the program and the way that the criteria were organized. So a lot went into sort of sifting through our existing set of expectations, identifying which ones didn't really add value, so they sort of were ready for retirement because everybody was doing them, or there just really wasn't a good way of demonstrating that such and such was in place. So we eliminated a number of criteria, and then we took the remaining criteria and a few additional ones and sifted them through this core and elective filter. Is this something that everybody should have to do? They don't, again, have to do it in a particular way, but you need to have something around access and something around same-day appointments, et cetera. And then, other things that could move into that elective category where it's more relevant if you're a particular kind of practice or you're serving a particular kind of patient population. We've organized the content. It used to be standards, elements, factors. We are now concepts, competencies, and criteria. The concepts really will look just like the standards that you're used to, that sort of overarching design of an expectation. Patient-centered access is one of those. Competencies are really the thing that we want to know you are capable of doing as a practice. And then the criteria are the bits and pieces that provide that demonstration that you are, in fact, operating as a medical home. So We're going to get now into these are the 6 standards, and I think on the next 2 slides, I'm going to show you the competencies that underlie those. So these should look very familiar to you. The part that I think the words that are on this chart that are new are the practice organization, sort of really emphasizing this need to set yourselves up for success, make sure that resources and, you've defined your team, that was already there, but that you've defined who is responsible for sort of championing the model of care and who is really working with the practice on the transformation. Again, we'll get into all of the bits and pieces in a moment. And then knowing and managing your patients is really that population health component of having some information, understanding who your patients are. So those are the only words, I think, that are on this slide that are new. But otherwise, the concepts are still the same basic concepts that we had before. So the competencies you can see laid out here. I'm, again, not going to go through all of the language here, but emphasizing this practice leadership, that if there aren't resources, if people aren't committed to this model, it's not going to be sustained. We really want to make sure that it is a sustained movement of the practice. Continuing to have that orientation of patients, so that's not new. Knowing and managing your patients, really having that understanding. You can see medication reconciliation sitting in there. That's part of that. Managing your patients, we eliminated things like e-prescribing because everybody's doing it. So it just didn't seem appropriate. We also eliminated that laundry list of demographic and clinical information that has to be collected on 80% of your patients. All that stuff, that's gone from the program. But what we're expecting is that you're using the data. So, we don't need to see that you've got the data if you're using it, and you show us that you understand who you're serving and you're able to deliver programs that make sense for them. Patient-centered access and continuity remains very similar to the past. Care management and support has, identify who your patients are and then put in place a patient-centered care plan. You'll see some interesting changes in that particular item that hopefully you'll like. Care coordination, care transitions looks a lot like Standard 5. There's really very little that's different from the past. And then likewise, performance measurement and quality improvement. We're looking for you to measure across that triple aim, all the dimensions of the triple aim, and act on the opportunities that you see in your performance data to improve. So this just shows you a lay of the land. How many of you have looked at our standards, the new format? All right, who hasn't even seen them? Okay, so this is what they look like. This is the basic framework of them. You'll see that concept area listed with an intent statement. We really tried to be briefer, but clear and to the point about what we're trying to get at in each of these content areas. We know that every practice is different, and how you're going to go about meeting the concept or meeting that competency is going to be different in your practice. So we want to lay out as much information as possible to help frame your flexibility so that you understand what are we trying to accomplish with this area, so that you can then show us, I don't do exactly what you said, what your words use in these particular criteria, but I do the intent. I meet the intent of this. So you get that opportunity to make your case as part of the review process. And you'll see in the tool, there's a place where you can say, I have X, Y, or Z documents or evidence that we've laid out or suggested, but there's also a place to say, I have other evidence. So, you can choose to show us something that we might not have even imagined that you're doing, because we know there's so much diversity out there in how you're going about meeting these requirements, and we want to create that opportunity and freedom for you to show your case, tell your story. All right, so it's laid out with these concepts, with an intent statement, a competency, and a statement about that competency, what the overarching idea behind that is, and then each of the individual criteria are laid out, and they will be laid out with the words core or 1 credit or 2 credit, because the electives have varying amounts of credit. And again, we'll get into the details there. So here is just laying out an example of sort of a competency area and then the range of core criteria and elective criteria that are available within it. And again, we'll be going into so much more detail throughout the day. I don't need to touch on that now. I've mentioned this idea that you're going to go through, you're going to engage with us early on, you're going to have committed to this transformation, you're going to transform alongside us, with us sort of guiding you through the process of recognition, not the actual transformation. We are not the on-the-ground consultant that is making all the changes or helping you to adapt the approach to your particular setting, but we are there to hand-hold through the process itself and how you're going to move through the transformation and demonstration to NCQA. Part of this was we recognized that a level 1 medical home was on its way, but not fully operating as a medical home, as what people intend when they think of a patient-centered medical home. We saw that in the sort of equivocal results that are coming out of research studies. When you mix together level 1s and level 3s, it becomes harder to see the impacts that a patient-centered medical home can have. And so we were committed to this idea that we need to draw a line between what is operating enough as a medical home to be labeled one and what isn't quite there. So you're in process, you are committed, you're transforming, but you haven't yet achieved a level of transformation that we think will have the desired cost and quality impacts. So that is the reasoning. We went away from having 3 levels of recognition to having a single recognition status. You're just going to be recognized under the new program. We will then have opportunities for distinctions, and I'll get into that in a moment, to highlight certain ways in which you are different or go above and beyond the basics of operating as a medical home and are doing something that's particular to the service of your community. All right, so I've mentioned this idea of 40 core criteria, I think I said that, and that there are 60 elective criteria, and as I mentioned, some of them have 1 and some of them are worth 2 credits if they're sort of more advanced items or more acknowledged to be more difficult to accomplish, and so you need to earn 25 credits. So that doesn't mean 25 electives, that means 25 credits across the 1s and 2s, you get to add them up. You do also need to meet at least 1 elective in each of 5 out of the 6 concept areas. So we want to make sure that you're spreading it around. That's not just you're really great at access and not doing so much in knowing and managing your patients. So we want to have some amount of mix, and we just set a pretty low threshold of at least 1 credit in each of the concept areas, but wanted to give you the freedom to have 1 that maybe you didn't meet. All right, so core criteria and then elective criteria. This is just little dots to show the same idea of you're going to earn up your credits, and the rest, don't worry about. You don't have to check every single box. We are encouraging people to maybe get a little more, or like strive for a little more than 25 out of the elective credits that are available, because what if you don't quite make 1? You want to have some flexibility there, freedom to have maybe missed something and still get all the way to recognition. But don't feel like you have to check every single box. That's definitely not how this is set up. All right, so here this is laying out how many core criteria there are in each of the standards categories, the criteria areas, and then this one shows how many electives of varying types. And I think that the colors are intended to say, okay, this practice maybe picked the red ones and they left the blue ones for another day or maybe the next evolution of their practice. All right, so I mentioned distinction modules. This is this opportunity to demonstrate excellence in a particular focus area. So an area of controversy with our 2014 standards was this idea of behavioral health integration. We sort of stepped up the expectations. We included more factors that related to this integration of behavioral health, and we definitely got a lot of pushback. Again, the intent was flexibility. It was not something that you had to have a behavioral health provider that was sitting in your site and delivering, kind of warm handoff care to patients who presented in that office, but it felt like we were having expectations that were unrealistic. So having this distinction now allows it to sort of sit apart and say, yeah, you do need to know about the behavioral health needs of your patients. You need to address the behavioral health needs of your patients, but you can take extra steps if you are a fully integrated healthcare practice where you have behavioral health providers on site and you have specialized relationships with behavioral health consultants out in the community who can be called upon in a moment's notice to provide expertise and provide training to your staff in order to help them meet their needs and do additional measures and have more tracking programs for depression management, et cetera. You can do those things, and that will help earn you a distinction in behavioral health integration. The basics are going to be in the core criteria, but there'll be others that will be standing apart and give you that opportunity, and we can get into more details. That hasn't been released yet. Have we put out the preview version? Did we share the preview version?
They should have the behavioral health one possibly in their packets.
We distributed it.
We did distribute it to this group.
Yes.
Okay, all right. So you've got those criteria, but we haven't built it out in QPass, which is a system you'll hear about later today, but it will be available fairly soon. So we're still working on getting it into the system. I went to that middle bubble first. The other first one is one that's been in place for a while. You can earn a distinction in patient experience reporting if you use the standardized patient experience instrument known as CAPS. It can be the CG CAPS or the PCMH version of CAPS. We are updating that distinction to reflect the newer version of the survey, the 3.0 one. Again, working on getting that into the new system, and so timing is still being worked out. But currently, you can still submit the prior version of the survey and get this distinction in patient experience reporting. Still trying to move towards a place where we have performance data that we can use as part of the recognition process, and ultimately to have distinctions for performance, achieving certain thresholds in performance. And likewise, so the new distinction on the right side, I guess on the right, yep, distinction in electronic measure reporting. So again, moving people towards standardized performance measures out of efficient sources, so electronic systems, being able to report using the QRDA3. Don't ask me what that is, I don't know. But the people that work with your EHRs do. And so, having a standardized way of reporting these measures, then ultimately having those measures validated in terms of how they've been calculated, and then ultimately, again, having performance data on which we can benchmark practices and award distinctions that are based on the performance of the practice rather than on, that you're doing a few more factors than another. So, all right. So here are those kind of the content areas of the behavioral health integration. We have the behavioral health workforce, sort of expanding upon the capabilities of your practice by having either additional resources or additional training for the resources that you have. Evidence-based care, making sure that that information is being shared and coordinated across the health system. And then measuring and monitoring, having quality measurement processes, and using data, evidence-based protocols to understand how care is proceeding and what changes might be needed in the care plan for an individual based on actual instruments that help you to understand, track the symptoms over time, et cetera. So those are the basics there. I've already talked about the patient experience, sort of enhancing, to use the newer version of the survey tool. We also are working on innovations in patient experience. We don't know what this looks like yet, but at some point when we have an actual project and a pilot opportunity, we're going to make that known to our practices. And if you want to participate in that, that will also earn you the patient experience distinction. And then finally, with the ECQMs, we have established a list of 35 measures. We selected them from the ones that are sort of nationally identified. They're part of the MIPS reporting requirements or PQRS, so they're not ones that we just made up. We identified measures that were available and could be reported electronically using this ECQM kind of specification. If the practice, for each clinician in the practice, reports at least 6 of those measures using the QRDA3 format, then they earn the distinction in ECQM reporting. As I mentioned, our intent is to step that up over time and expect the reporting to take place through a certified measure reporter. So your EHR or your data aggregator or an HIE in your particular community can get certified that they are producing the measure properly. We know that there's a lot of error in the programming that goes into the production of those measures. And so that's one step on the validation journey. We're not quite sure how to deal with the completeness of the data, but we think that if you know that the measure's been calculated properly and then you see that your rate isn't what you expected it to be, that's your opportunity to say, wait a minute, what am I not documenting? What am I not getting into my system in order to really understand what my performance looks like, and more importantly, how to manage my patients? Because if you don't know that they had this service done, then what do you do? Like how do you know who to intervene with? So important to get our data systems really working for us so that you as a practice can meet your patients. And then we have the pre-validation program, which you maybe, how many people know that we have a pre-validation program or what even that might mean? All right, so not a lot actually. So pre-validation program is intended for vendor solutions that meet some of the expectations of the patient-centered medical home on your behalf. So we can review what that EHR vendor or care management vendor is doing. We can review that once, and then you just say, yep, I'm using that solution. That's how I go about doing the tracking of labs, or that's how I go about doing reminders for my patients, et cetera. They've got embedded decision support tools that are based on evidence-based guidelines. So those solutions can come forward to NCQA, be reviewed once, and then they'll be automatically credited to you when you identify, yep, that's the system I have, and I am in fact using it for those functions. So we have transitioned. Have we fully transitioned all the existing ones? Do you know? Are we done with that?
They haven't finished.
They haven't, okay. So the vendors are still transferring their credits from the 2014 program to the 2017. I will say, we have 11,000, well, maybe it's a little less than that now, 11,000 outstanding tools for the 2014 program, tools that have been purchased but not yet submitted to us. So we know, there's a lot more 2014 business going on over the next 6 months or so. And so we've got staff trying to live in both worlds. Anyway, so the pre-validation program's still up and running, still working well for the 2014 practices. It's getting transferred over into the 2017. The new tool, the new QPass tool, is going to have some nifty features that will sort of automatically check all those credits that you get to earn by virtue of using. So you're just going to say, I use eClinicalWorks, and you'll submit your little letter that proves that that's the version you have installed, and then it's going to just know what to give you credit for. How cool is that? So I'm very excited. It's all thanks to Bill. If you hate it, it's all thanks to Bill. So anyway, so that is, that's the basics of the pre-validation program, and I think that ends my introductory remarks. And I am a little ahead of schedule. So we have time for some questions. And then I don't know whether we want to do the Commit, Transform, Succeed and then take the break after that. All right. So are there any questions? Please come to the microphone if you have any questions.
Good morning.
Good morning.
I would just ask you that some of us are really, really newbies. So
Yeah.
when you refer to, oh, it's just like the 2014, I
Thank
don't
you.
know what the 2014 is.
Yep.
Okay, so I don't
Yep.
want, okay, that, I just appreciate it.
Yes.
Because there was some things that you went over when you had all those little dots there in the 2 slides before that went completely right over my head.
Okay.
So are we going to circle back to
Yes,
that?
so that's just a graphic depiction of core and elective, and it's new to everybody, and it's, we're gonna be going through the actual criteria. That's what really matters, and we're gonna identify, here are the expectations. We're not gonna spend a lot of time saying, and that's the same as we had before. You know, we might say that a few times just to kind of help people out to navigate from, you know, their current knowledge to the new knowledge, but we will make sure that we're going over the actual content. What is the expectation today throughout? Okay, thank you
I
for
do want to
pointing
just
that out.
make a point about that little graphic with the dots. It's really important to understand that you're going to be doing some exercises, especially if you're attending the advanced, that help you figure out which electives really fit with your practice. And so the idea is, in that graphic, is that you're going to select some in all different areas. You need to cover 5 of the 6 concepts, and you need to reach 25 points. But other than that, it's completely up to you to decide what really fits with your practice. So it was just to give you an example. This is what one practice might have selected in each of those concept areas. You can see there's a varying number of electives in each of the areas, and so, you know, there's a more or less choice in a few of them. And so, you know, that's something we just wanted you to give you a general idea of one of the things that you'll need to work on as far as deciding when we present these elective criteria, like, no, that doesn't fit my patient population, or that doesn't really, I don't have the data to do that. Skip that one. You know, you don't have to try to do all of them. So you might want to do a self-assessment first and figure out, well, these are the things that we're pretty able to do now. These are the things we might have to work on. They make some sense for us. So, you know, it's just a process, and so we wanted to give you a quick view of something you'll need to tackle as you go about the new program.
Yes.
Right, so I had a question with regard to, you mentioned clinicians seeing 75% of their patients, and I guess I need to better understand that, because what we've done in order to increase access is to increase the number of same-day and walk-in appointments, which means that the providers are seeing less than 75% of their patients.
Yep. So you're speaking to continuity of care within the practice for the particular designated clinician, whoever they've chosen. When I talked about eligibility criteria, I was talking about the practice as a whole, that, you know, we know that there are practices where they might have a sort of urgent care capability within the practice, and they might see some episodic patients. Those aren't continuous care patients. They're not part of your panel. So we're saying the majority of what you do needs to be about serving as the primary care patient-centered medical home for that patient on an ongoing basis. It's not about, do they see their assigned clinician? We do have a criterion that we'll get into in the access that says you should track what that continuity looks like. How often are patients able to see their assigned or chosen clinician, but you get to set the threshold, and you get to decide what should that look like. And absolutely, things like what you described are part of what's going to influence you know, how often they see the exact same person and how often they just see part of the team. And, you know, if you've got a good team communication process, that should still offer continuity. So we're not going to judge your actual percentage and the continuity, and you'll see that criteria as we go further into the day. Okay?
Hi, Tricia.
Andy.
Can you go back to slide 32, please?
I can try, yes. That one?
Yeah, great. Thank you.
Great.
Okay, so the text in red are the concepts.
Correct.
Is the text in black competencies or criteria, or is that just body copy descriptors?
They're competencies. Those
Okay.
are the competencies that you'll find in each one.
Okay. And since you were just there, can you flip forward to 33, please? What do the blue indicators signify? I think Mina was referring to this a moment ago. On the far left bottom left corner, and on the right edge, there are blue sort of arrows.
They were probably intending to go to a description. They might just be random.
Yeah, so this actual slide is a screenshot from our actual preview document for PCMH. So where you see the little parts dropping off, they're going to more summaries of what the little pieces meant. So a summary of what TCO1 meant. So really what they're describing, I can just go over it really quickly, is just indicating like, hey, this is how we describe or name the actual criterion, and they come in 1 or 2 credit increments. So it wasn't anything we're missing. We've all covered it in terms of the slides going forward, but it's just a little snippet of what our preview document looked like.
Got it. Okay. Thank you both.
Okay.
Hello. So is the QPass replacing the ISS?
Yes, it is, and the application portal. Oh, look, yay. We all agree. It's okay.
So you'll do everything in the QPass?
You will do everything in QPass. And is the demo today or tomorrow? Tomorrow? Okay, so tomorrow we'll give you a demo of it. Pardon? Yeah, you'll see some snippets of it today. But yes?
So I wanted to ask you more about the distinction models.
Yes.
Modules. It sounds like they're not ready in the IT system yet. So if folks are trying to prep towards 2017 standards, they probably should just hold off and wait until that piece, or no?
Nope. We have issued the preview document, and you have it as part of your materials that you got for today. If we don't have it already up on our website, we will have it up there soon. And we have the list of the measures in there, so you can begin prepping for it. You just can't input the answers. Many of the criteria in the behavioral health distinction are actually in the program. They're just in there as electives. And so, when you've selected them as electives within the main program, they'll automatically end up, marking them as completed in the distinction. But we will have that up and running fairly soon. I think it's this month? July, okay, July. So it will be in there very soon. You shouldn't hold off. And the preview criteria tells you the basics of what the expectation is so that you can begin to prepare.
And a follow-up question on the E-Measures reporting.
Yes.
You mentioned about having certified reporters. So I'm from HRSA, so I have to ask, so if there's a health center control network that supports the health centers in reporting, can they become a certified? How does that process work?
Yes, let's engage, and we'll get you a card and make sure we connect you with the folks that are doing the actual measure certification. You know Bill. Okay, Bill's going to take care of that. Yeah.
Just a quick question with the going from ISS and the application process to the QPass. We already have 19 practices with all their practitioners that I keep up with in the application process. Is that going to flow over? Please say yes.
You'll have a lot of typing to do. It'll be fun. No. What we decided to do, it was really a choice between making people redo all of that work, which we didn't want to have happen, or try to move everything from our database, which is actually Salesforce. So everything that you were working on fed into Salesforce anyway. Okay. You didn't know that. So we've moved everything from Salesforce into QPass now. So everybody with an existing recognition was part of the RP program already, those organizations are all in QPass, along with any users that were authorized in their application portal. So that was a legal determination that those are the only ones we could decide were actually appropriate to have access.
So if we presently have a lot of practices in the applications that have not yet finished their surveys, and so they're not presently 2014 recognized. So those I would have to rebuild?
No, if they're currently part of the Salesforce account, which sounds like they would be, if we know they exist, they were moved into QPass, unless there was an error in which we can fix that later. But you'll have to add any new sites, and you may have to change your users. We're also finding, and this is the other problem we had, is that a lot of folks have more than one organization account.
Yes.
But it's all one organization. So we're doing a lot of merging right now. So
Okay. All right. So
this is also
stay
part of our
tuned.
movement to this.
Okay.
Yes.
Thank you.
But you'll be good.
Thank you.
Kind of along the same line, I have a multi-site, we have about 20 practices, so I'm the only practice right now certified. But are we gonna be discussing multi-sites at all? Okay, I'm probably a little bit ahead then, okay.
Yes.
Did you,
I think that's tomorrow,
did you
right?
point out where shared is in the,
I don't think I did. Is it on, is it on a slide?
yeah, well.
I don't think it shows it on
No, I
the
mean,
slide.
it's in the.
Oh, in the actual standards book.
Standard.
Yep. So within the standards book, we've identified criteria that can be shared across multi-sites, or actually just across any sites. So you know, we have a designation if you have at least 3 practices that share a lot of stuff, that means you're a multi-site practice, but you can share just with one other practice a particular criterion. So there's going to be a place where you can set up your sharing and your site groups. You could be one big organization that has 2 different EHRs, so you'll end up with 2 site groups, but you then could still share some things, policies, across both of those site groups all together. So there's a lot more flexibility in that sort of sharing of criteria, and there's a little thing that looks like you're sharing things. Like there's a bunch of arrows. And you'll see that a lot of things are shareable. And, you know, there are some cases where we still need site-specific information to be contained in that shared material. So like a report that's about your quality. You know, we're going to need to see that you're measuring every site, but you could show us that once in one document, so.
My
Yes.
main question is, if you have multi-sites, do you all have to submit at the same time? Or if I choose to do 5 here, 5 next year, is that possible
Yes.
to do that? Okay.
Yep.
Thank you.